Noon. Try to make up time if I can. So I got asked to present My Great Stroke Save was the title. And so I was looking at a save, and it's a catch-22 when you get asked that, because for it to be a save, it means you had to do something pretty dumb or bad beforehand to make it a save. And this is certainly one of those cases. And since I was on a theme, I threw on a second one that's in the ballpark of disconcerting. These are disclosures. None of them are relevant to this or discuss anything related. So this is my stroke case. So a 78-year-old woman comes in. She has an NIH stroke scale of 10, mostly aphasia with a little bit of weakness. This is her CTA. We believe in non-invasive large vessel occlusion confirmation with angiography with everyone. If you look at it, there's a pointer here. You can see carotid bifurcation to MCA and ACA, and on the left side you can see a thrombus that's just hanging into the ICA, occluding the left MCA, but you still see filling there. There's good collaterals on that side. However, she has a clear deficit and a strong ACA on that side. You also may notice that she has a pericallosal aneurysm that we don't intend to do anything for at this time. We bring her emergently to angiogram for treatment, and you can see the angio confirms what we saw, pericallosal aneurysm and a clot that's just hanging into the ICA bifurcation at the carotid T and is completely occluding flow into the MCA. You may also know she has reasonable collateral flow coming over the top of the ACA and coming down towards the MCA on this angiogram. So I go up. This is a number of years ago, so this is before the current stent retriever technology. It's also before we started using aspiration the way we currently use it. So for those of you that are not familiar, we first had the first approved device for this was a device called the Mercy Retriever, which was like a corkscrew that you deposited and pulled it out. I'm good friends with the guys who developed it. It was great in terms of starting this whole direction, but it really didn't work that well. And then the next generation was what was called the penumbra aspiration system. That involved using a wire to sort of break up the clot as you sat there and sucked adjacent to the clot with aspiration. Sure, sorry. That would break up the clot and allow you to aspirate it. And we had that for a number of years. It worked okay. More recently, aspiration technology is used to directly cork the clot and remove it completely. We've gone to much larger catheters. Back in this era, we would be using an 041 ID catheter to perform this. So we went up with that 041 catheter, did aspiration, used the separator to try to break up the clot, and you can see aside from pushing it distally into the M1, we did not really achieve a good recanalization. So back in this era, with the Mercy and just the old penumbra system, what we usually defaulted to was then use angioplasty and or stenting. In fact, at this time, I just completed a trial called CERIS, which was with the Buffalo guys, built off of cardiology to do primary direct stenting for acute intracranial occlusions. So I went up with a small, just a 1.5 millimeter diameter, I think it was a Maverick, slightly overinflated, just to open up enough of a channel, get flow restored, maybe give a little lytic and allow it to clear open. So I did what I would typically do, go up with the balloon, do the little angioplasty, let the balloon down nice and slow, do a run, and I get this picture. So now I'm pretty happy. I've got great anterior grade flow. Everything looks pretty good. The balloon's still in place, and but it's ugly, right? The vessel's quite narrowed. I'm thinking this is probably going to re-occlude or get worse. And this is a lesson not to overdo it. I have a theory, be very quick and have a low threshold to do a little, but don't necessarily overdo it. At the time, my two older boys now, but they were younger, just is around the same time I was taking pictures, and everyone's happy and they're looking great, and I'm still shooting, trying to get the best shot, and I don't anticipate that my older one's about to dump all the leaves on my younger one's head and make it a much worse situation, and that's what I did here. So I say, look, I haven't moved the balloon, I haven't done anything, I'm just gonna reinflate the balloon one more time, touch it up, make sure the clot's out of the way, and then finish it up. So I put the balloon up, I let the balloon down, and I do a run, and I get this massive extravasation from the MCA and into the vasculature. You can see the wire still sitting there. Somehow I ruptured the MCA. So at this circumstance, first I needed, someone mentioned maybe not needing atropine, but something to slow down the heart on that earlier case. I quickly brought the balloon back and inflated it just to cork the origin of the MCA. So I didn't want to reinflate where I'd already ruptured the MCA, so I inflated it at the ICA bifurcation and then allowed it to ride up and just plug the origin to the MCA. I then kept checking the vitals, said a lot of prayers, and left it up for about 35 minutes. She had good collaterals, as I'd mentioned before. She was in IH of 10 prior, and I'm thinking I will kill her if I don't get this bleeding stopped, but if I just end up with an occluded vessel like it was before, at least hopefully I didn't do too much harm. So I left it up for about 35 minutes, very trepidatiously let the balloon down, did a run, and it looked like this. Awesome, totally open, everything was done. So I don't know that I did much saving except for stopping the bleeding from continuing, and I think that it made sense to not re-angioplasty right at the place, but to do a more proximal occlusion. But this is really a case of better lucky than good in terms of getting away with it. So she's now got this excellent perfusion anterior grade. She has no significant narrowing in the vessel. Her MRI shows a little bit of basal ganglia change, but the rest of the brain looks quite excellent. And more importantly, this is her the next day. And she looks pissed because she was reading the paper, and I asked her to stop and stand up for me to take a picture because I couldn't believe she was still alive. But she has a bit of a facial, a little bit of a hand drift, but her NIH improved to an NIH of 3 or 4. So it was a great save, but also very good to be lucky. So just as a short, sort of similar follow-up, this is a gentleman that I treated here about here. Yes, please.
So, I mean, amazing case. What would you have done if you had been taking pictures and saw collateral filling of the perforation?
It's a great question. I would have to figure that out at the time. Well, I'll show you what I did here. I didn't actually have the tools that I used in this case during that case. But here's a case of, you can see an irregular anterior choroidal aneurysm that was projecting laterally and was giving the patient a third nerve. And so we brought it. He also has, by the way, you can see projecting superiorly an A1 aneurysm just by the bifurcation. A1 aneurysm pointing up, but here's the symptomatic one with the little daughter sac and bleb. So we said this is considered imminent for rupture when it's newly symptomatic, and we should treat it. So I do a fair amount of balloon remodeling for these cases. So you put in a double catheter, you put one into the small aneurysm, the other one you occlude the parent vessel, and I used a super compliant balloon, and I inflated it on purpose, a bit overinflated, because I wanted to pooch into the neck of the aneurysm to protect the anterior choroidal. So I did that, put the coils in. Actually, I had my fellow put the coils in. I was managing the balloon. He put it in. He was all excited. It was the first one he had completely embolized. Gave a high five, put the balloon down, did a run, and saw this. That's disconcerting. So in this case, I didn't think we have a good ACOM. We have the whole vasculature. I didn't think coming proximal and trying to stump anything was going to be helpful. He has a PCOM. So instead, I reinflated exactly in the situation where I was, right here. And you can see now the balloon's much bigger than it was on the first time and is pooching out. I don't have a picture of the lateral, but it was pooching out laterally. I then I did some control runs and slowly deflated to make sure that I wasn't occluding the top of the ICA so that collateral could come across from the ACOM and fill the MCA on the other side. And I left it up for about 30, 40 minutes, let it down, and did this run. And so now there's no more active extrav. There's a large pseudoaneurysm right in that region. The anterior choroidal that we coiled is completely gone. The anterior choroidal artery is open. The ICA A1 aneurysm we never wanted to mess with. So now I have to decide, what am I going to do in this circumstance? So he's got it. When I saw that rupture and I put the balloon up, the next thing I did was run around to the head and put an external ventricular drain into his brain to relieve the pressure and allow the fluid off. So now he's got a fresh drain through his brain, so I don't want to load him on aspirin and Plavix or Integralin or anything like that and precipitate a worse bleed. So at this point, be quick to do a little. We stopped. We kept him under general, kept his blood pressure extremely well controlled. We watched him in the unit for a few days. We have ICPs from the EVD, keeping his blood pressure low, and and I weaned his drain and took it out because I only put it in because he had had this acute rupture. Now I feel like I can give him blood thinners and the rest. So we bring him back and pipeline him. And so we put 3 flow diverting stents, pipeline embolization device. They have about 33% metal coverage over this whole region, which you can see on those images, which went very smoothly, and we got a great picture. Unfortunately, after I put the pipeline in, had him on double antiplatelets, he started to develop hydrocephalus. So then we had to re-put in a drain, put in a shunt. We did that. We're really happy. He goes to rehab, actually. We're quite excited. And then he comes back with this giant subdural in that circumstance. So burr holes, stop the antiplatelets. This is the soonest I've ever done it on a pipeline patient, which was about 3.5 weeks. Kept him on just aspirin, ligated the shunt, evacuated the subdural. And luckily, a year later, the subdural's gone. More importantly, the aneurysm's completely gone. Interestingly, the A1 aneurysm also went away with the flow changes. It's completely disappeared. And he's completely intact and normal. So it was a slog. He was in the hospital for a while, but we got him through it.
How did the A1 aneurysm disappear?
Because the flow diverter, you'll see, I placed across the origin of the A1 into the MCA.
All right.
So as a result, over time, as that endothelialized, it became a dead pouch and went
Diverted.
away. Yep. Changing the flow dynamics, essentially, made it go away.
What catheter did you use for your pipeline, the delivery catheter?
Typically now I use an XT27. I'm not sure if it was out. I might have used a Marksman in this case.
Okay.
Either a Marksman or an XT27. XT27 Stryker, Marksman's Medtronic. They're 027 catheters. 027 catheters. And the guide catheter there is a benchmark, or probably a Neuron back in the day, but now a benchmark.
Do you think the wire injuries, why the ruptures, both rupture?
I think that this was a disease.
Wire
I think
injury?
this whole artery was a disease segment. We talk about this a lot when we go in to do surgery for these aneurysms, that there are patients where the carotid
Yeah.
is sort of like tissue paper and really bad. I think that's what it was, and I think I ruptured it with the balloon. I tore through it. I didn't appreciate it. I made a conscious decision to a little bit overinflate to try to protect that choroidal,
Yeah.
and it was more than the vessel could handle. The intracranial vessels aren't that forgiving, and it's certainly something to be cautious about. Thank you guys very much.